Welcome to those who are just joining us. We appreciate you being here today. Thank you so much for taking the time out of your day to spend with us this morning. We have invited everyone to introduce themselves in the chat. You can introduce your name and the organization you represent and your position if you're interested. My name's Danny LaForest. I'm the Workforce Development Liaison for Greater Health Now, and I have the joy of helping to plan and facilitate these learning collaboratives. So we always like to land here on this welcome screen and share our purpose and intent for the learning collaboratives. So I'll just go ahead and read it and share what we had in mind. So the purpose of the Learning Collaborative is to create and sustain a learning community that raises awareness and inspires personal and collective growth. These meaningful engagement opportunities aim to ignite participants to contribute to transforming systems that foster community wellness. So we are so grateful to everyone for joining us today. And we will go ahead and get rolling. So today's topic, we're excited to introduce this week's topic, which is preparing to bill for health-related social needs, becoming a Medicaid billing entity and beyond. At Greater Health Now, we know our partners have interest in learning more about potential funding opportunities, and we are eager to learn more together. So Greater Health Now is committed to being a neutral convener, bringing experts in their field to provide real-time information about current topics. In the evolving landscape of healthcare, we are often learning alongside our audience and are unable to predict what the future will hold. We know that every organization's path is unique, and in no way are we recommending or endorsing a single pathway as it relates to this topic. Thank you again for being here today and engaging with us. So today's learning outcomes will be to identify the steps to becoming a Medicaid billing entity, to understand some of the above available health-related social needs programs to bill Medicaid, including foundational community supports, and to learn about the golden thread of documentation. So I am thrilled to introduce our presenters from the Healthcare Authority Foundational Community Supports Program. Anessa Williams serves as the Foundational Community Supports Supportive Housing Program Manager for Eastern Washington at the Healthcare Authority. With a bachelor's in sociology and a master's in public administration, Anessa has over 7 years of dedicated experience in the field of social and health services, with a focus on serving unhoused individuals and families. Lissa Bailey serves on the Washington Healthcare Authority Foundational Community Supports team as a management analyst. Before coming to HCA in 2023, Lissa had numerous years in assisting Washingtonians in financial and health services, working with Medicare billing and claims and Washington housing grants for new home ownership. Lissa serves the team with her knowledge of Provider One and working on multiple projects to ensure accuracy, efficiency, and program support. And finally, Elizabeth Pitts is the Foundational Community Supports Program Manager, formerly Apple Health and Homes Program Manager at the Washington State Healthcare Authority. With a background in human services and dual master's degrees in public administration and social work, they contribute experience in health equity, state-level policy, and nonprofit programming. So with that, I will turn it over to our wonderful presenters.
Great. Thank you so much, Danny. I think I'm going to get us kicked off here today. So thank you so much for joining us. We can go ahead and just jump into the overview slide. So we're going to kick off today by talking a bit about becoming a Medicaid billing entity. This overview slide is just the steps all in one spot, and then I'm going to go ahead and break down each step for us today. My expertise with becoming a Medicaid billing entity really comes from the Foundational Community Supports Program. And so this is kind of generalizing beyond that. So for more specific questions that you may have, I might refer you over to our Provider One team, but I'll try my best to give you the information and answer whatever questions you may have. That said, if you do have questions, feel free to hop off mute and just ask your questions as we go along. And for any really specific or technical questions, we can take those offline. I'll be sure to provide my email in the chat. For now, you might have gotten a chance to peek through these steps. Step one in becoming a Medicaid billing entity, you're going to want to obtain your NPI. And so that's something that a lot of folks might already have, but if your organization has not, that is done through the National Plan and Provider Enumeration System, otherwise called NPPES. And that NPI number, if you're not familiar, is the National Provider Identification Number that will connect your agency to the identification system and registry that we utilize for Medicaid. So once you have that number, it's important to verify that you're an eligible provider under the Washington Administrative Code 182.502.0002. Again, I have all this linked, so when we send out the slides, you'll be able to explore these further. But we'll talk a little bit more about what does eligible provider type mean and what are the types. Or what are eligible providers. And then you'll determine a provider type. So this will be either individual, group practice, facility, etc. Again, we'll go through a little bit more in detail what that means. There are required forms that need to be completed to be submitted with the Provider One application, and that's different depending on how you are applying. And then it's just a matter of completing that Provider One application. So we'll go to the next slide and talk a little bit more about what it looks like to obtain that NPI. So this is the first step. An NPI is a unique 10-digit number assigned to you through that national provider, the enumeration system, which keeps a registry of healthcare providers nationwide. And there are two types of NPIs. Type 1 is for individuals such as therapists or individual doctors, and type 2 is for organizations such as a clinic or an agency or a group practice. So it's important to select the correct type based on the services that you intend to provide and how you intend to bill. You can also select up to 15 taxonomy codes, and these taxonomy codes describe your specialty. So for example, if you are applying under the Foundational Community Supports Program, common codes that we have folks use include case management or community and behavioral health. But there are a bunch of taxonomy codes to help you identify what your practice, what makes most sense for you. There's also a helpful guide, and I attached that link into this slide as well, which kind of walks you through how to apply for an NPI online if you are needing step-by-step instructions. On the next slide, step 2 is verifying that you are an eligible provider. So you need to confirm that you meet the eligibility requirements set by the state. The WAC, or Washington Administrative Code, that I mentioned outlines who can enroll as a Medicaid provider. And so this varies by service type. So for instance, if you're a chemical dependency provider, there's a certain certification that you need to document and submit along with your application. The HCA website has a detailed list of eligible provider types as well as their specific requirements, which I highly recommend reviewing to make sure you have everything you need. Next slide. Okay, this is a pretty heavy slide, so I'll walk you through it. So step 3 is determining your provider type. So this guides which forms you fill out and how you will bill. So a billing provider is a provider that delivers services and submits claims directly to Medicaid. And you'll see that there's a link for each of these. So that's something that folks can click the link through links and be able to explore in their own time as you're working through how this fits for you in your practice. A non-billing provider um, may deliver services under a managed care or behavioral health contract, but this is a provider that doesn't bill Medicaid directly. So this includes those who order, prescribe, or refer services. If you're a healthcare professional under a group of or facility, that group must also be enrolled with a core provider agreement on file. And then the other category is if you're a billing agent or clearinghouse, and there's a separate enrollment process for that. So make sure to select the category that best describes your role and how you plan to interact with Medicaid billing. And so that's likely one of the top two options that I've put here, whether that's a billing provider or a non-billing provider. And I think another one of the differences is um, the sorry, the word is escaping me, but the documentation you have to provide on the back end for that billing is maybe a bit heftier for the billing provider as opposed to a non-billing provider. But for the FCS program, we specifically work mostly with non-billing providers. So that's where I have a little bit more knowledge. And then we can move over to the next slide. And so step 4 is completing those required forms. And again, this is determined by that last slide if you're applying as a billing provider, a non-billing provider, or a billing agent or clearinghouse. For that other option of healthcare professional practicing under a group or facility, there's no additional forms that are required unless you have some sort of certification that you determined you need to add in one of the previous steps. For billing providers, there's that core provider agreement again, a debarment statement, copy of the IRS W-9 forms, any supporting documents that are practice specific, and there's an optional trading partner agreement. For billing agents and clearinghouses, that trading partner agreement is not optional. And then for non-billing providers, there's a non-billing provider agreement. And then you're either going to fill out an individual non-billing form or an organizational non-billing form. And those get submitted along with the Provider One application, which is on our next slide. So once all of those materials are ready, you've made all the determinations of how you're applying and what documents you need, you'll head over to the Provider One portal to submit your application. So you can start your enrollment at the link that I provided in this slide. And once you begin, you'll be assigned a 14-digit application ID number. And so it's really important that you write this number down or log it somewhere because it's the key to saving and returning to your application. You do not need to finish the whole application in one sitting. If you save this ID number, you can start it and come back to it, which I highly recommend because sometimes you might have questions and need to come back around. And it can also be helpful too if you are troubleshooting with our provider enrollment team and they need to access your application. You can provide them either that 14-digit application number or your NPI so that they can find you in the system. So if you run into any issues, that provider enrollment support team is going to be your best friend. They're available by phone, their help desk on Tuesdays and Thursdays. And you can also reach out by email any other day. Once you submit, it typically takes a few months to hear back depending on application volume and whether or not anything is missing from your application. A tip that I have is to reach out to that help desk and just kind of check the status of your application. I can't personally expedite any applications. It's kind of just on the whim of the queue. But staying kind of in the loop can be helpful since it can be a bit of a long wait. And I recognize that that phone number, the extension is one digit too long, so I will put the correct extension number in the chat. Um, and that's it as far as the Medicaid billing entity application step. So I will go ahead and pause for any questions. Okay, hearing none, I will keep checking the chat. If you do have any questions, I will pop my email in the chat for you all. It's elizabeth.pitts@hca.wa.gov. And if there's any way that I can support or get you connected to the right folks to help you along in this process, please let me know. I know it could be a bit daunting and a bit complicated. So thank you. And I think on the next slide, we're passing it over to Anessa.
Yep.
Great.
All right, so just to shift into some of the specific programs that you might want to learn more about or utilize. For some context, Elizabeth and Lissa and myself all work for the FCS team, which is under the Medicaid Transformation Project 2.0. The Medicaid 1115 transformation waiver, I'm sure lots of y'all in this call are familiar with it, but just in case you're not, it was originally awarded in 2017 and it launched a bunch of different state programming, expanding Medicaid services for eligible enrollees in for support in things like housing, employment, SUD treatment, peer support. This graphic here just kind of shows a bunch of the different programs that we have available now. And then in 2023, the project was renewed for an additional 5-year demonstration period. And we're going to be talking about a few different areas of MTP 2.0. Full disclosure, my area of expertise is in FCS. So I am giving an overview of several different other programs. And if folks have more in-depth questions about those, I might have to refer you to somebody else or, parking lot the conversation. But we will definitely do our best. And I see a question in the chat here about there being a pause on FCS contracts. That is true, and that WellPoint is not currently contracting any new providers. That's just temporary. I wish I had more information to provide as far as when we expect they'll be contracting again. But yes, that is correct, Moses. Next slide, please. Okay, so one of these programs is the Medicaid Alternative Care, also known as MAC. This is a really cool program that provides services to folks, provides support services to unpaid caregivers, and it's supposed to assist them in providing care to their family members while also improving their own well-being, basically with the intention of helping these caregivers continue to provide care for that family member since they're not being paid for it. The requirements are that the caregiver is 18 and over and the individual they're caring for is 55 and older. And that is something, eligibility screening can be done by area agencies on aging. And I have linked a map in here. I believe everybody gets the PowerPoint afterwards. It'll show you the AAA map as far as where they are in each county and service area. And next slide, please. And then the reentry demonstration initiative. This is for if you're working with folks that have been justice involved. This allows Medicaid reimbursement for pre-release healthcare services up to 90 days prior to release, provided to anybody who is incarcerated in a Washington state facility. And services that you can provide to them include things like case management, med management, meds for alcohol and opioid use disorder, medications during the pre-release period, lab and radiology, services by community health workers with lived experience, so peer services, that kind of thing, and physical and behavioral clinical consultations as well. Prior to this, folks were not able to get served until after they were released because that's when their RAC code would change. But now, luckily, we can start providing some of those services prior to release so that you're not releasing somebody, to homelessness or to the exact same situation they were in before where they're lacking a lot of those important resources. So that was a really cool change. Next slide, please. All right. The True Blood Settlement, also known as Forensic HARPS, provides short-term housing assistance and support to folks that have been involved in the forensic mental health system that need help accessing independent living options. And services within that include things like housing transition services, like landlord outreach, care coordination around housing, individual housing and tenancy sustaining services. That's also involved in FCS, which we'll talk about shortly here. And it's estimated at $500 of spending per enrollee for up to 3 months. And I have put the email here of Sarah Taylor. She is our FHARPS program manager at HCA if you have additional questions about that. And we can go to the next slide here. Then school-based behavioral health services. If you are working in schools, working with students, this provides funding for schools to do things like audiology services, mental health services, including individual and group counseling, nursing services, occupational and physical therapy, and speech language therapy services. These services are all reimbursable when a student has a Title IX Medicaid coverage, and the services are included in the student's current IEP plan or individualized family service plan. So this would be primarily for students that are in regular public schools, as those are the ones that are held to those standards. And next slide, please. And we've got the PACT program. Program for Assertive Community Treatment. So this is a community-based mental health program that provides intensive individualized support to folks with serious mental health conditions in their homes, with the goal of helping folks improve their quality of life. Different things that they can work on with this program include daily living skills, social and interpersonal skills, 24/7 crisis intervention, which is amazing, SUD treatment, care coordination, housing and employment supports. That's not a comprehensive list. That's just a few of the things. And then if we could move on to housing resources, I could do a bit more of a deep dive here. And we can click to the next slide. We're going to be talking about FCS, Foundational Community Services. If this is a program you're not familiar with, it's a targeted Medicaid benefit to help folks with complex health needs obtain and maintain housing and employment stability. So that includes supportive housing and supported employment services. FCS is not any kind of ongoing payment for housing, rent or room and board costs. We do have some really exciting programs for that now. Apple Health and Homes and the HRSN, which is going to be starting soon. But FCS in and of itself does not cover housing in any capacity. It's not wage or wage enhancements for the supported employment side of things. And it's not an entitlement, meaning that just because somebody has Medicaid does not mean that they automatically qualify for FCS services. There's some other factors that need to be taken into consideration there. And next slide, please. And Elizabeth, I'll pass this one back to you since it's about AHA.
Yeah, thanks, Anessa. So this is a little bit more in-depth information on the Apple Health and Homes Rental Assistance Program, also known as AHA RAP. AHA RAP has 3 main forms of rent assistance. So we have the tenant-based rent assistance, or TBRA vouchers. And the TBRA vouchers are selected through a weighted drawing, which selects, I believe, this most recent drawing that we did was 59 vouchers across 10 regions. And this allows folks to receive a voucher that they can go shopping with, and a shopping letter that they can bring to landlords. And once they are leased up, the Department of Commerce can pay rent directly to the landlords on behalf of tenants. So it's just the TBRA that are part of that weighted drawing. The project-based rent assistance units, or the PBRA units, are announced to our provider network for enrollees to apply to. So there's no drawing for these. It's just based on notification, and they have tenant selection plans in place so that they can make sure that they get those units filled with AHA eligible enrollees. And then we have our capital units. Um, with those tenant selection plans, and they receive referrals for Apple Health and Homes eligible enrollees. And so to break down eligibility, TBRA eligibility is a little bit different from the PBRA and capital unit eligibility. So for TBRA, somebody needs to be enrolled in the FCS supported housing program. They must be age 18 or older, which is different from our FCS eligibility of 16 or older. So just a note there. And they have to meet specific risk factors and the definition of a homeless person. And that's determined by another Washington administrative code. And so that's what that links to there. And then for the PBRA or capital eligibility, it's the same, except they have to meet the definition of at risk of homelessness, different from the definition of homeless person. So again, I've linked both of those so folks can kind of explore what those differences are. And again, just noting that this is a really cool benefit, and the Department of Commerce is who is paying rent directly to those landlords on behalf of the tenants. So if they are in FCF supported housing, and they meet those criteria, then there are a few options to get them connected to housing vouchers through Apple Health and Homes. I'll pass it back to Anissa.
Next slide, please. Okay, community-based health rental assistance, otherwise known as CBRA. This is for folks who will be discharged from psychiatric state or community care who have been discharged within the last 12 months. This can cover some of the same housing costs as TAP, which I'm actually surprised we didn't put in a slide on, so we'll talk about TAP a little bit too. TAP is our transition assistance program, which is for FCS enrollees that are making some kind of housing transition, which can be, from moving from homelessness into housing or from one type of housing situation to another. It covers some great costs, including things like first and last month's rent, moving and storage fees, application fees, cost of replacing IDs and social security cards. It's a very flexible funding source and can cover up to $5,000 per enrollee every year. The only issue with TAP is that funding runs out really fast because everybody swoops in on it. It's coming back in July, and I would anticipate if we keep following the same pattern we have been, it'll probably be gone within like a month to 6 weeks afterwards. But it's a fantastic resource to utilize while it lasts if you are working with somebody who is making some kind of housing transition and needs help with those big upfront costs. And CBRA can cover some of those costs as well, like I was saying. Eligibility for CBRA, as you see here, has to meet income criteria. At least one adult member of the household must also meet all of these criteria below as well. Having a documented behavioral health condition, eligible for long-term support services, and a documented need for long-term housing subsidy with no other suitable resource that can meet the long-term subsidy need. And next slide, please. And Glide Path is also a really cool program. This is for households that were formerly utilizing HEN but are losing HEN benefits, or have received a HEN referral but were not able to identify permanent housing within the last 6 months, or received rental assistance in the past but exited the program within the last 6 months. So It's a transitional funding source to help folks bridge that gap. GlidePath can provide some really cool reimbursements for folks that are working on re-entering the workforce. I will put our coworker Kimberly's email in the chat here. She is in charge of the GlidePath program, and she's gotten things like wheelchairs and other assistive equipment for folks. It's a really cool resource to utilize. All right, there's that. And additionally, households enrolled in FCS supported employment should be prioritized, and household income needs to be at or below 80% AMI. And we can go to the next slide here.
So you did get a question in the chat.
Oh, I'm so sorry.
Oh, that's okay. It was just, is GlidePath only for those on FCS?
I don't believe so. I think FCS enrollees are just prioritized, as it says here. But it doesn't exclude those that are not enrolled in FCS. And Elizabeth or Alyssa, feel free to correct me on that if I'm wrong, but I think that's accurate.
So GlidePath does not have to be FCS enrollees, but people who are in FCS can utilize GlidePath for additional benefits. So like currently right now with our GlidePath program, we have each region in the state has a specific GlidePath provider. And right now we have like a mobile device program that's going until the end of June. So if you are enrolled in GlidePath and FCS, then you're eligible for a mobile device up to $300. But you do not have to be enrolled into FCS to obtain GlidePath benefits. No.
Thank you, Lissa. And these are just some additional resources that can be helpful. I'll walk through these real quick. We've got the Discharge Planners Toolkit, which is really great if you are working with somebody who is being released from some kind of institutional setting. It is a sort of like a decision tree kind of tool. You can go through, answer questions, and at the end you will get an outcome of here's some resources that this person would be eligible for. The subsidies and landlord resources matrix is awesome as well. It breaks down all of the different housing programs, who is eligible for them, what they cover and provide. Washington State Housing and Employment. Oh, and Pathways to Employment and Pathways to Housing. Pathways to Employment is currently getting a revamp. It's going to be really cool in a few weeks here. We're adding a bunch of new resources. Pathways to Housing just got a big revamp last year, and it's got amazing resources for folks who are seeking housing, housing providers, and landlords as well. There's lots of trainings on there, different tools. Definitely would check that out. That one's also linked underneath all of our email signatures. I do not believe we have an active training and event calendar anymore. FCS newsletter. FCS supports provider map. So the provider map shows the state of Washington and breaks down all of the counties and what providers in each county are accepting referrals, which ones provide housing services, which ones provide employment services, and which ones provide both if you are trying to help a participant access services. Lisa, do you have something to add to that?
Yeah, I was going to jump in. I have kind of taken the provider map under my wing, so I've been working to make it a more accessible tool for everyone, and I've gotten a lot of provider feedback because we have quarterly calls with our providers to check in for like a collaborative unit or a learning community. So we have added ALSA services onto the map. We have also added TAP providers onto the map. I'm working on creating an additional filter for utilizing youth resources. So if providers have youth programs that they're using. So if there's any feedback that you guys have, please send it on over to me. I am always wanting to make it a more reliable and accessible tool for all the providers.
Thank you so much. That's awesome. And then we've also linked WellPoint's FCS page as well. WellPoint, I don't think we've discussed yet, is our third-party administrator for the FCS program. So they manage enrollments and do some quality assurance pieces, things like that. We could go ahead and go to, you know what, I'm going to pause there. That was a lot of information thrown at everybody at once. Do we have any questions on any of the programs, any of the funding sources, any of that stuff before I move on to talking about documentation? All right, if anybody thinks of something later on, again, feel free to unmute yourself or just put it in the chat. We keep these very conversational as much as possible, so no worries about interrupting us. With that, though, we'll move on to the golden thread. And if the golden thread is not a term you've heard before, it basically refers to tying together a person's story through all of the different pieces of documentation, all of the different interactions you might have with them. So that includes treatment plans, case notes, um, diagnoses, goals, any of that kind of thing. Basically, we want to be able to look at any one piece of documentation about a person and understand why are they seeing you for services? What are you helping with? How did this get them closer to whatever goal they're working on? We can go ahead and move to the next slide here. So components of documentation can include assessments, treatment plans, and case notes. In the context of our work on the FCS team, assessments often look like a housing assessment of some sort, like helping somebody figure out what kind of housing might be best for them, what kind of housing they'd be interested in, or on the employment side of things, doing job discovery. What are they good at? What do they like doing? What kinds of skills can they bring to the workplace? Assessments can be very casual and conversational rather than formal. Um, it's a great way to build rapport with clients and start building a foundation of trust. And I think that's a lot easier to do when you can take your time with it. It can be over several different meetings. Treat it more like a conversation, getting to know somebody, than we're going to go down the list and check off all these boxes. And it's just that's the way that I would recommend going about it for the sake of building rapport with clients. But we can also, if anybody is interested, I have sample assessments that I could send out with the follow-up, if that would be at all helpful. They can look very different depending on the kind of services you're providing to somebody, but sometimes it helps to have a template to look on. Treatment plans as well. Treatment plans should include short-term and long-term goal planning. And I'll talk about this further, but it's really important that the treatment plan is being very much led by the participant. We've got a good analogy for that, which is basically the participant is the driver and you are the GPS. You can offer different routes to take and tell them, give them all of the information that they need to choose the route that they want, but ultimately they're the one in the driver's seat. It's their life, it's their decision. You're just providing the information that they need to make that decision. And then case notes. For the sake of Medicaid billing, every single interaction needs to be documented in a case note, even if you tried to call them and they didn't answer, even if you had an appointment and they didn't show up, even if it was just a quick 5-minute conversation, that all of that needs to be documented for the sake of care continuity, for the sake of making sure that we are keeping track of all of the work that we're doing, et cetera, et cetera. Let's move on to the next slide, talk about treatment plans. Whoops. So treatment plans can also be referred to as housing stability plans, care plans, person-centered plans. It really depends on the kinds of services that you're providing, but it all refers to the same thing. Next slide, please. We'll talk about the different components of assessments and treatment plans. So they can look many different ways, but they should have these 4 components at least. There should be some kind of problem statement. So why are they seeking your help? What are they hoping to get out of the interaction? A goal statement. What are they working towards? An objective. Just how are they going to get to that goal? And then the intervention. Just what can you do and what can they do to meet that objective? And next slide, please. Just important things to remember when you are creating a treatment plan with somebody. You want to make it measurable. So think SMART goals, right? There should be a specific timeline to each goal. There should be an end date in mind. And it's absolutely okay to not, meet that end goal if things end up taking longer for whatever reason, but we want to make it measurable so we know that we're making progress, right? And that can often look like breaking things down into smaller steps as well. Using participant voice is really important. We don't want to use overly clinical language because that doesn't sound like the participant, right? And when this is being looked at by a third party that might not know this person, might not know the interaction, if it doesn't sound like them, it doesn't sound like they were actually involved in the treatment planning. And for the sake of it being Medicaid billable, it needs to be very individualized, and there needs to be evidence that shows, yes, this person participated in writing this treatment plan. This person is the primary author of the treatment plan. So I always recommend using direct quotes as often as possible, using the language that the participant is using. You don't have to make it sound, clinical and official and diagnostic. You can use their language as much as possible. For the sake of housing, goals should always be linked to housing, or if you're offering employment services, linked to employment, obviously. That being said, though, there's a lot of different subcategories under that could still be relevant for both. For example, considering housing, different kinds of goals could be, pre-tenancy, tenancy sustaining, maintaining physical health, maintaining mental health, because if you're doing those things, you're going to be better equipped to maintain your housing too. There's so many things that you can work on with somebody that can be tied back to either housing or employment, even if they don't seem like a direct correlation. Every billable case note needs to be linked to a goal in the treatment plan, right? So if you are doing care coordination and helping somebody find a mental health counselor, they need to have a goal in their treatment plan about getting support with their mental health or something to that effect in order for it to be a billable service. It's really important that treatment plans are very much like a living document, ever evolving and changing. If you're going to continue to work with somebody and continue to bill for them under Medicaid, we need to see that they still have things to work on. They have new goals when goals are being met. So as often as you can update a treatment plan, that's really important. And it should be used as a regular tool too. Treatment plans aren't just, this is some mandatory paperwork that you have to do. It should be informing every interaction that you have with somebody and really used as a tool for the participant to see, what are my priorities right now? What action steps am I taking to work towards my goals? And like I was saying too, breaking big goals into smaller ones to make them more achievable, right? Find housing is a huge goal that has lots of individual pieces under it. That could be broken into, I'm going to call 3 landlords a week. I'm going to replace my ID. I'm going to write a letter to a landlord regarding what is in my background check. Lots of little steps under that can be broken down so that it feels like you're accomplishing things rather than, oh my gosh, we've been working on finding housing for 6 months and I'm still not housed. Okay, next slide, please. We're going to talk about goal development. So this is what a sample of a treatment plan might look like. Starting with the problem statement at the top, and that should be where the participants' direct words are, right? And that can sound like something like, for example, I lost my apartment because I let my boyfriend move in with me and he wasn't on the lease and the landlord kicked us out. The goal that you write in collaboration with the participant in response to that problem statement could be something to the effect of, Susie wants to find a new apartment that she and her boyfriend can live in together. Right, pretty simple. And also on here, we like to see these pieces like strengths. So what is this person good at? What qualities do they have that are going to help them find and maintain housing? What kinds of skills and knowledge do they maybe need that you can help coach them with? What kinds of natural and community supports might be helpful as well? Or, are there more people that we can bring to the table to support this person? What barriers might get in the way? And again, a great opportunity for participant quotes, desired results. How are you going to know that you met the goal? How are you going to know? Sometimes it's really obvious, like, how are you going to know when you're housed? Well, you've got keys to an apartment. But for something like a goal relating to mental health, it might look like I'm only having 1 panic attack a week instead of 6 or something like that. Or I feel happy day to day. And we can move to the next slide. All right, getting into the objective section here. This is where SMART goals go underneath the umbrella of the goal statement and can be broken down into those action steps like we were talking about. So an objective under that goal might be Susie will work with the case manager to apply for a Section 8 housing voucher. And the category here, this is what I was talking about earlier, is categories might be pre-tenancy, tenancy sustaining, employment sustaining, social connection, legal, life skills, benefit planning and income planning. Any of that kind of stuff is totally relevant to put in. And then the action steps too. And I want to point out here, you'll see the column that says person responsible. That can be, this is the case manager's responsibility, or this is Susie's responsibility. And the target date is the date that you want to have it done. The completion date is when it's actually done. It's just a helpful format to break it down into. They don't all have to look like this, but this is just an example of what a treatment plan can look like for this section. Okay, we're going to, I'm gonna pause there. I feel like we're going through pretty fast. I just want to check, does anybody have any questions about any of this before I move on to talking about progress notes? All right, we can go ahead and advance the slide then. Okay. Does anybody want to come off mute or put in the chat if you are in a role where you have to do progress notes or case notes, or if you have been before, why are they important? Why do we have to document?
If you don't document it, it never happened.
Absolutely. I love that answer. Can't even say how many times I've told somebody that. Appropriate reimbursement. Yeah, absolutely. When Medicaid is reimbursing the service, they want to make sure that they are paying for the service that's appropriate under the program, right? We're not going to reimburse somebody for something that has absolutely nothing to do with housing or employment, even though I would argue you can tie just about anything back. Sabina, I see your question in here. Does this have to link to a clinical provider? Can you expand on that question?
Yeah, hi, this is Sabina. I'm working for a new community health center in South Seattle. We are training some community health workers, and we are noting in the chart what they are doing in association, like with the patient's clinical chart. And we're trying to figure out if it has to be linked to a particular provider's like ICD-10 code for that encounter, or if these CHW notes and their documentation could be separate. It doesn't have to be linked to a particular patient encounter, and they could just occur independently.
For FCS documentation, progress notes do not have to be connected with any specific clinical provider.
Okay, thank you.
Yeah, of course. I also want to call out these comments in the chat as well. Looking at the progress from previous notes, absolutely, and making for better care coordination. Those are both great answers. I want to also touch on some points here. Somebody's case notes are considered, part of their medical documentation. They're HIPAA protected. They're also something that could potentially be viewed by a lawyer. I've absolutely seen that happen before when somebody is, maybe getting evicted or having some problems with their landlord, and takes that to court. Sometimes the case notes can be looked back on for evidence of, did they cause this damage, or just an example. But yeah, they're legal documentation, so it's important to have everything documented that you possibly can. Additionally, the client should be able to request all of their documentation from you at any given time, right? It's about them. Really, it belongs to them. And if I was a client, I would be pretty disappointed if I asked my case manager for documentation and they're like, oh, I haven't been keeping track of our conversations. That would make me feel like I'm not being helped, not being listened to. I think that ideally documentation should be done as soon after the interaction as possible. That's when you're going to be getting the most accurate recall of your information. Had lots of conversations with case managers while I was a provider about like, hey, if you're case noting an interaction from 3 weeks ago, it's probably not going to have all the same detail that it would have if you wrote it, later that day. And documenting non-billable services is important as well. So like I was saying earlier, even if you, try to contact somebody and they don't answer or they no-show you, or you're only talking to somebody for a couple of minutes, none of those are billable interactions, and we still need to make sure that they're being documented. For example, say you have been trying to call somebody, trying to contact them, trying to go to their usual spots to find them, and you're not able to keep track of them. And then they complain, I've been waiting for my voucher for 6 months and I keep trying to contact you and I can't get a hold of you. You can say, well, no, I've been keeping track in my case notes. I've been trying to reach out to you several times a week and haven't been able to get a hold of you. Just one example of how that's helpful. But also, even documenting non-billable services still helps to illustrate, all of the services that you're providing, all of the care that is happening for somebody. It's an important part of the story. Next slide, please.
Vanessa, you got another question in the chat. Will you be discussing the Z and G codes for these notes later?
Z and G code. I'm sorry, I'm not familiar with what that means.
It's Sabina again. I guess there's certain types of codes associated with documenting social determinants of health that can be put in the patient encounter to help boost billing.
Liz, are either of you familiar with Z and G codes? I haven't heard that term before.
I haven't heard of Z and G codes. Is it when you're billing like inavailability and submitting claims to WellPoint for reimbursement?
It is for reimbursement.
Okay, so that might be, if you're already an FCS provider, that might be something you'd want to talk to the FCS WellPoint manager about, your FCS manager through WellPoint. If you're having coding issues or rejected claims. I'm not sure what the Z and G codes would be for.
Okay.
Um, Z codes are the diagnosis, actually, like housing instability or nutritional instability. And then the G codes are what we actually file the claim for billing under.
Okay, thank you.
Okay, next slide, please. There's lots of different formats for case notes. This is just one example. This is a DIP or a DAP note. The description is the, oh, you know what? I go into more detail with these in the next slides. Basically, the three components are describe, the intervention or action, and then the plan. We can go to the next slide to talk about description. So the describe part is basically all of the objective information. Who was there? Who was it? What were they wearing? Were there any changes in their baseline behavior, changes in their hygiene? What was the context? Where were you? What time was this taking place? Was anybody else there with them? It's important to note too, for the sake of HIPAA and privacy, if you are meeting with a client and there is somebody else there as well that you are serving, it's important to only use your client's name rather than use both of their names in there. So, for example, if you're seeing two participants you're serving at once, you would need to write two separate case notes. You know, for example, you could put, I met with Susie and her roommate, or, you know, you don't want to put two people's names in there, but it's important to note if there was somebody else there, like their roommate, their child, spouse, anything like that. But yeah, description is all just objective information. We could move to the next slide. So the intervention is, what did you do? How was your action linked to their treatment plan? What are you doing to help the participant work towards their goals? And what are they doing to work towards their goals? So we'll talk about this in the next slide too, but ideally at the end of every interaction you have with somebody, both of you are coming away with what are we going to work on next time and what are we going to work on until then. And we can go to next slide. So the plan section, what's the plan for your participant between appointments towards their goals? When are you going to meet again? Where are you going to meet again? And what are your plans for your next appointment together? What are you going to accomplish next time? Next slide, please. Documentation can look a little bit different specifically for FCS versus for FCS if you're doing housing versus employment. Both of them need to have the date, the writer of the case note. So always, you know, sign it off with your name and your title. It should very clearly tie back to their treatment plan, you know, read over it, double check. If it doesn't seem like it ties back to their treatment plan, what can you add to make it more obvious? It can be really helpful to end a case note with a sentence, something to the effect of, you know, I helped Susie talk to a landlord today because this is going to help her find housing, which she has stated is one of her goals. You know, if you have to spell it out and make it really obvious, that's totally fine. Doing weekly or monthly summaries to show low engagement interactions can be really helpful as well. Maybe for folks that you're not doing as intensive services with or more of those non-billable services. A weekly summary for somebody in that situation might look like, you know, I saw Susie in the hallway 3 times today. I asked her how she was doing. She said she's good. She asked if we have any food pantry items, and I gave her, you know, some canned goods and some bread, something like that. The difference between housing and employment here is housing billable interactions only require the total time spent. So you can say, you know, you spent 90 minutes with somebody. Employment wants you to be more specific and specify the start and end time. You can also do that for housing too. It's just not required. But I think that's because housing and employment are billed differently as well. Employment is billed in 15-minute increments. Housing is billed in per diem increments. So that's why that's different. And that brings us to the end of our content. We got through that way faster than I thought. That golden thread was a very quick summary. Next month, we have a full length, like 2-hour golden thread training. If anybody is interested in a deeper dive on documentation, I'd be happy to link that in the chat. That was just kind of the speedy overview because it usually takes quite a long time to go through. What questions do we have about billing, about programs?
Hi, this is April with the Everett Recovery Cafe. I had a question about, sorry, I came in late. And I was under the impression that this was going to be about FCS and beyond, as in like other billable contracts that were possible, like if you were a certified peer. Did I happen to miss that?
I'm sorry, like, do you want us to, we do have more time. Do you want me to go back and talk more about FCS? I don't have anything in this PowerPoint about peer services specifically, but I'd be happy to connect you with my contact at HCA, who's the program manager for the peer department.
That would be amazing if you could do
Okay.
that.
Yeah, I'll put her email in the chat here. Are there questions about the FCS program? Because that's all of our area of expertise. We'd be happy to talk more about that.
I just have a question.
Yeah.
So what I don't remember which slide it was. I think it was the person before you discussing on, I'm gonna forget the program. There's a lot of acronyms. So some of those, maybe it was Apple Health and Homes. The commerce dollars, or talking about that rental assistance, I think I heard said goes directly from commerce to the landlord. Is that correct? Or is it funneled through a contracted community partner?
Correct. So when a tenant is leased up in a building, the Department of Commerce pays their rent directly to their property management or their landlord.
What's what's that connection time? How fast does that take for a landlord? Because the challenging part sometimes is finding a landlord willing to work with an external partner or somebody else outside of that tenant. What's the kind of connection time from the time they receive contact or request to actually receiving the payment?
So so when somebody goes through the lease up process for Apple Health and Homes, they have paperwork that they bring to the landlord that the landlord can fill out and connect with the Department of Commerce. And then they are able to pay that rent directly on a monthly basis as anybody else would. So there shouldn't be a lag time when it comes to that payment, as opposed to like if they paid it directly to the tenant and then they had to go ahead and process that over. So from my understanding, direct payment is like if I paid my rent directly as well. It's just coming from the Department of Commerce based on like the information that they've been able to get into their system from the landlord. And so it's all based on kind of like what that voucher paperwork looks like as a potential tenant is working with that property management. It's a bit more seamless when it comes to like the project-based and capital units, just because those are working already directly with the Department of Commerce. But for TBRA, we haven't seen we we haven't experienced any sort of like lag time when it comes to paying the rents.
So is there anybody walking alongside most of these clients that do have this benefit to help fill out a lot of this paperwork and walk through it?
Yes, so that would be their supportive housing provider, and those are billable services under supportive housing. So as people are seeking out vouchers, working through the paperwork, shopping around for housing, these are billable services through FCS.
Thank you.
Yeah, thank you.
Amber, I see your question in the chat. Most of this is discussing case management, but not necessarily the physical health side, like active TB case management. I would say anything physical health related is relevant for billing under FCS. Obviously, if somebody is not getting adequate care for their physical health, it's going to be very difficult to maintain or find housing. Does that answer your question? I would say, as far as there's different providers that specialize in different things, like might be better at managing somebody with complex physical health needs, but it's absolutely a billable service to assist somebody with physical health. Amber, what more information for what specifically? FCS or I'm not sure about TB case management specifically. I'm not sure of specific resources for that. And Leona, you're asking for more information for how would an agency be able to get information for an existing HEN client that's not enrolled in GlidePath? sorry, like get information to the client? Are you asking like how a client could be connected with GlidePath if they're not already connected with GlidePath? Okay, yes. Depending on the area that your participant is in, there's different GlidePath contractors throughout the state. What area are you located in? Oh, thank you, Lissa.
Great. Any additional questions for our presenters today or points of discussion?
This is Melissa from Columbia County Health System. I read this as being something related to the April 9th announcement from the Healthcare Authority that as of July 1st, 2025, we would be able to be reimbursed for community health worker time through Medicaid. Do you guys know if there's going to be any kind of, and that's I think what was referenced in the Z and the G codes, because we're using those for Medicare reimbursement right now. And I'm just wondering if there's anything on the docket or coming up in the near future for Greater Health Now that we could get some education or additional support as to how we could start our billing for those services through Medicaid before
Can you
July.
can you do me a favor and email me the announcement you're talking about, and I'll get you connected with the right resources for it because I'm not sure if I've seen the one that you're talking about.
Okay, yeah, I'm looking at it right now. So
Awesome. Thank you so much.
I will. Do you have your email in the thing?
Yes, I just put it in there.
You just, okay, awesome. I'm gonna copy and paste it right now for you, Anessa.
Awesome. Thank you.
Yeah.
I can actually answer that question as well. So, Greater Health Now won't be revisiting that topic, but the presenter from last month's presentation, Nikki Banks, who was talking about the CHW billing guide, has some open forum settings coming up. So she has a couple of presentations specifically about the billing guide that was just released. So I can put that information in the chat as well.
Thank you, Danny.
Thank you.
Great. Well, I want to take a moment to just thank Anessa, Lissa, Elizabeth. Thank you so much for this robust content. We really appreciate all of the information that you shared today. It was a phenomenal presentation, so informative. So thank you very, very much. And I believe you all actually have a slide for an event that you have coming up that we were going to have you share about.
Yes, that's right. Yeah, I would love to plug our workforce recruitment webinar, How to Attract Talent and Create a Sustainable and Inclusive Workforce. We know that in any kind of social services, healthcare related field, turnover can be really high due to the stress, the burnout, oftentimes low pay. This is going to be a great webinar if you're trying to figure out how you can attract good people for the jobs and keep them around. That's going to be April 29th, 2025 at 1 p.m. and meeting registration is linked below as well. And please, everybody, feel free to continue reaching out to us, utilize our email addresses. We're very accessible. My role especially is intended to be very provider facing. Doing training, technical assistance, answering questions is a huge, huge part of my job. So please feel free to reach out at any time. And even if it's a question I can't answer, usually able to connect you to the right person. And thank you so much, Danny, for giving us this platform today. I do hope that it was helpful.
Absolutely. We really, really appreciate it. And we'll just take a few moments to wrap up. I do want to mention I am exceeding the character limit in trying to send over the CHW billing guide information session. So I will include those in the follow-up email for today's event. With that, that is all the content that we had planned for today. We wanted to mention that in totally coincidentally, we also have a webinar about recruitment and retention strategies coming up. So similar topic, different forums. We'll send the information for both of these out. Our registration page is here, linked QR code. We will have the Healthcare Authority's partnership with the University of Washington Behavioral Health Institute talking about their recruitment and retention toolkit. And then we will also have someone from the Sentinel Network talking about a previous year's collection phase. We also wanted to mention that the Sentinel Network is opening their collection period for this year. So we will send the link to be able to contribute to the Sentinel Network as well. And finally, if you have a few moments, we'd love to hear your feedback on today's topic and presentation. You can scan this QR code and we will be able to get a short survey from you with just a few questions, including recommendations for future topics. So if there's anything that you'd be interested in learning more about, we would love to hear those from you. And I will just conclude by once more thanking our wonderful presenters. Thank you so much for your time today, and thank you to our audience for being here. Thank you for your engagement and your questions. We really appreciate you, and have a wonderful day.